Hi everyone, welcome to Pathology channel. Today we are going to learn about the basics of breast pathology. So we are going to see beyond the basics in the breast pathology. So before that, if you want to see many pathology lectures of mine, kindly like and subscribe my channel and follow it. Okay, so moving on to the content, initially I'll be discussing about the basic histology, then about the basic cytology, and then a grossic technique. So all these three is very important in a postgraduate level. So I'll be concentrating mostly on this. So anatomy. So before moving on to the histology, we should know the anatomy of breast. So you can see from the deeper to the outside will go. So the first one is ribs, and then comes the muscle, then chest wall is there and everything is there. Then is your fatty tissue. So surrounding the breast lobules, the fatty tissues will be there. So then lobules, lobe, ducts, and finally nipple. So this is the normal anatomy of breast basics. So why am I showing this broccoli in my pathology? Because we pathologists, we usually imagine things. So here I compared the broccoli to make it very easy. So let us see along with it. So the total rectangle which indicates the TDLU. What is TDLU? It is a terminal duct lobular unit. So that is a functional unit of breast. So that is your TDLU. Next, if you see the second arrow, that indicates intralobular terminal duct. Okay, so the next one, the whole circle which indicates the lobule, it's collectively called as, and the small circle that is labeled as a ductule. And finally, in between the two lobules, there is something called as a stroma. So that is your lobular stroma. So we just compare the broccoli with the breast anatomy. So this is all about the histology. Also, we will get into the idea once you understand this picture basically. And here you can see I'm going to go along with the breast comparison with the tree. So how I'm going to go with it? The first one is cluster of grapes is there. So I'm comparing this with the lobules. So all the lobules will have acini, the ducts, and they are arranged in a kind of a cluster of grapes. And the next one, the ducts. So these ducts are compared with the branches of the tree. Okay, so here in the histology image you can see there is a duct, and inside that there is a secretion. So we are comparing it with the branches of the tree. And the third image, that below you can see the histopathology of nipple. So you are seeing the above layer, that is your epithelium. So below you can see there is some adnexal glands, and also the ducts are there. So this is compared with the trunk, where the lobules are the one which secrete and the ducts are the one which carry, and finally the nipple is the one which is discharging the milk. Like that you can understand. So ultimately for every tree there should be a support system, that is a soil. So here the soil we are comparing it with stroma. So this stroma is nothing but they have myoepithelial cells and all the fibroblasts. So all this connective tissue, everything together is called as stroma. Okay. And the next, myoepithelium. What is the specialty of myoepithelium? This myoepithelium plays a very vital role in many organs like breast, prostate, and everywhere. Okay, salivary glands. So what does it indicate? They act as a gatekeeper. So if you see here, I have compared it with the fence. So they are like a barrier. So the tree should be protected, the small plant should be protected by the fence, or else some of the animals will come and engulf it. So like the same way, this myoepithelium is like a barrier for the tree. So that is why they are compared with the fence. So if you understand this tree, 80% of breast pathology is done over here. Okay, and little bit again I'm going to compare something with the sunflower. So why there is a sunflower? And here we can see this sunflower that has a central lumen where it has a lot of seeds. Actually this is the image where it shows a lumen. Okay, so that we are comparing it with the lumen. And the petals, there are two layers. One is inner circle, that is your pink color cells are there. So they are labeled as epithelial cells. Okay, so the inner layer of petal is compared with epithelial cells, and the outer layer you can see the orange cells are compared with myoepithelial cells. So these are the gatekeeper for the breast usually. And if you see that the stem is compared with the duct, and the leaves are compared with the fibroblastic stroma. So the entire unit is called as TDLU, that is your terminal duct lobular unit. So this is how we compare the sunflower with the histology. So simplify. Okay, so the image credit goes to below, which is this slide. I thank her really, because she's the one who is in artifying pathology, inspired me a lot in this. So and along with that we have expressed the ER, PR and HER2. Okay, so their expression will be more in epithelial cells. So that is how we differentiate. So in normal breast they express differently, and in malignant cells they express differently. So that is how we always do hormone panels for the breast cancer thing. And myoepithelial cells, the markers include the panels that is P63, calponin and SMA. So all these are markers for the epithelial and myoepithelial cells. So you just have to know what is it, that's all. So with this idea, let us compare and see with histology image. Okay, so here the first circle, that is the TDLU. So that is your terminal duct lobular unit, which is the functional unit, where the most of the breast diseases occurs here. Why? Because they are more harmonically active, and the proliferation will be very high in this particular area. So there will be more proliferation, more diseases will happen in TDLU. So the next image, the circle highlights the duct. Okay, so this is the duct in the breast. How does it look? And the third circle indicates the acini. So acini is compared with the cluster of grapes. So here you can see there is a lot of acini, what is there in the breast. And in between this lobules there is something called as stroma. There you can see the connective tissue which is in pink color, and there are few blue cells, that is your fibroblast. So this is collectively called as intralobular stroma. And here there is something known as interlobular stroma in between the TDLU. So this is how we differentiate. All these areas are harmonically active, and every ER, PR or HER2 is expressed in different area. That we will see in very detail in the next few classes. So since we have the image like a cluster of grapes and tree and duct and everything, so compare this histology image with the cluster of grapes. So all these are collectively called as the TDLU, and the side may you can see there is a longitudinal thing which is coming, that's your ductule. So all the secretion will be happening in the TDLU, and it will be collectively gone into the ductule. So this is the histopathological overview. And if you see this image, the second image below one shows you very clearly there are two layers of epithelial cells as we compared with the sunflower petals. Okay, so the inner layer is your epithelial cells and the outer layer is your myoepithelial cells. So these, I told you, they are a gatekeeper. So once the myoepithelial cell is lost, then it goes towards the malignancy. So that is why the myoepithelial role is very much important in histology of breast pathology. So you can see the red arrow indicates the myoepithelial cells, which is the gatekeeper, and as you see in the compare with the sunflower image. So next, coming to the breast, which is not it's not just a gland, it's a dynamic organ. How come? Because they changes according to the age, hormones and everything. So there is a lactating breast and there is a non-lactating breast, and finally this organ keeps on changing with age, hormones and life events. That is what we are trying to say. So let us see this rough diagram which is made. You can see the first one. The first circle indicates how the duct and epithelium will be present in the birth. Okay, so here the mammary bud formation will happen. So once there is a bud formation, the ducts and lobules will be formed a little bit, but the mesenchymal will be little less. So this will be happening at the birth stages. Whereas in puberty, what will happen? These buds will form a canalization. So once the canalization is formed, they form the duct system. Okay, so that is usually the duct lumen will appear after the puberty. So the next image shows you the pregnancy. So in pregnancy, how does it appear? It usually responds to your hormones, that is your estrogen and progesterone. So estrogen, because of estrogen, there will be a marked ductal proliferation and branching of epithelial hyperplasia will also happen. So the next one is progesterone. So progesterone will produce a new acini, and there will be edema in the connective tissue, and finally there will be pre-secretory changes during pregnancy. So next, moving on to the lactation. Here during lactation there will be a marked lobular hyperplasia, and the cells will have a large cytoplasm which is truly vacuolated, you can see, and that particular appearance is called as hobnail appearance. So this lactating breast is usually the cells will look bizarre, so the people may get confused with malignancy. So you should always have that one. There will be a hobnail appearance, and the ductal lumina will be filled with secretion, where the protein kind of secretion will be there. Okay, and post lactation, what will happen? These acini will become small and flatten. So that is what will happen. So the lipid droplets will be there due to the resorption of milk will be seen, and the fibroblast and collagen production will also be happening. So next, in the postmenopausal changes, so due to hormonal influences, what will happen? There will be a marked atrophy of your lobules and ducts. Okay, so and the connective tissue and fat will become more predominant. So with this rough diagram image, whatever is made, will compare with the histopathology image. So here in the childhood, you can see there is a formation of the glands, but there is no duct lumina is formed well versed. So the second image you can see in the adult, where the entire unit is formed and it's trying to hyperplasia is happening here. So there is lot of acini which is seen over here. And the third image shows you the lactational changes, where you can see particularly the hobnail pattern, and in the center of the lumen you can see there is some pink amorphous material, that is your protein material. And postmenopausal, as we told, there is a loss, there will be a atrophy of your glands and everything, where the fat will be replacing it. So that is what we are seeing in postmenopausal image. So here comes the heroine image. So this is Angelina Jolie. Definitely we have to talk about her when we are talking about breast pathology. Okay, so you all know that 2013 she have written in the New York Times what she had told. She's changed the story, the way the world that looked at the breast cancer in 2013. How sometimes the bravest decision is not about treating the cancer but preventing before it begins. That's what she does. So she was not talking about the movie, she was not talking about the frame, and she was talking about the genes. You people know that. So she lost her mother at a very young age due to the breast cancer. So when the doctor tested her with the BRCA gene mutation, so which has 87% risk of breast cancer and 50% risk of ovarian cancer. So with all this, she came to be BRCA positive, and she made very bold decision, not out of fear but out of knowledge, because there is a risk of getting cancer. So she chose the preventive mastectomy in 2013, followed by a bilateral salpingo-oophorectomy by 2015. So that is the one where it became as an awareness to many people. They routinely do mammogram and screen themselves, and they do genetic tests and everything. They are becoming more precautious. So it is very important. So a little bit about the risk factors of development of breast cancer. So it may be due to the germline mutation, that is your BRCA1, 2 or other hereditary genes, or it can be due to the family history, first degree relative whoever is having. So that is also one of the kind of risk factor. And the third one is environmental factors. Due to radiation, cigarette smoking and sedentary lifestyle, everything adds on. And the next one is a benign breast disease which has atypical changes. So those also comes under this. And the age, so usually it increases after the menarche. So that is what they give us an age. And also the high fat diet, lack of exercises, using OCPs. And also in Western countries and breastfeeding women, it can happen. And along with that, early menarche, late menopause, obesity, everything adds on. So here the story begins. We have to talk about pathology. Okay, so every cell there will be a change in genetics. So what is here they understood in breast cancer is in 1970s and 1980s, the researchers identified there is some familiar clustering. So they did a lot of research, and in 1990 they found the BRCA1 gene which is having the hereditary correlation with the breast cancer. And whereas in 1994 to 1995, the researchers identified the BRCA2 gene. So the BRCA1 gene is located in chromosome 17, whereas BRCA2 is located in chromosome 13. So that is what they detected in the further research. What is this BRCA gene? We have to know little about the BRCA gene. So usually in our body, there should be always a balance. Okay, for like oncogenes and tumor suppressor genes are there. So both should be in balance. What if the oncogenes are higher side? So then it will promote to more towards the cancer. Okay, what if the tumor suppressor gene come down? So the suppression of tumor is lost here. So the patient will have a more risk of developing cancer. So that is what they are trying to say. So this BRCA gene is a tumor suppressor gene, whereas they involved in DNA repair. How do they repair? They usually have MMR protein and many things comes under. Okay, so once they involved in DNA repair, if there is a one single malignant cell, it goes under the cell cycle. So if you imagine, this is the cell cycle where it has G1, S and G2, M phase. Whereas the cell enters the G1 phase, okay. So something happens and there will be a G1S and G2M gatekeeper will be there. So usually these abnormal cell will be detected by the gatekeeper, tumor suppressor gene or whatever it is. So once it is detected, either it will undergo apoptosis or it will undergo cell repair. So either the repair should happen or the cell should undergo death. But what if this both mechanism fails? So then comes your malignancy. That is what they are trying to say. So this tumor suppressor gene, they usually involve in DNA repair, BRCA gene, where specifically they repair the dsDNA breakage. And once by the predominantly they do by homologous recombination repair, okay. So once there is defect in this particular gene, there will be a abnormal cell which is entering the cell cycle and leads to proliferation of more abnormal cells, ultimately leads to cancer. So that is what, once there is a defect in the BRCA gene, it leads to cancer growth. Okay, so here is a simplified diagram. Wherever there is a instability in whatever tumor suppressor gene, either the cell should undergo apoptosis or cell repair, or finally if nothing happens, it moves on to the malignancy. Okay, so this is mainly, how does it happen? This BRCA gene either can be a germline mutation, or it can be one allele which is already defective, or it can be Knudsen 2-hit hypothesis where the second allele defect will happen later, or it can be the DNA repair failure, and finally everything adds upon and leads to genomic instability. So once there is instability in genomes, and it will ultimately lead to tumor formation. So a little bit we have to know about this BRCA1 and BRCA2 gene. So this BRCA1 gene, if it involves in pathway, what will happen? The tumor will present as very high grade and it will be usually triple negative. Why it's triple negative? Because they usually involves the estrogen receptor pathway and which regulates the transcription. Ultimately it decreases everything, okay. So and also involves the basal cell differentiation pathway, and HER2 amplification is basically driven by ERBB2 gene. So here everything comes out to be negative in the BRCA1 gene, and in those particular tumor there will be high mitosis, pushing margins and medullary like features. So all this favoring very poor prognosis. That is what they are trying to say. If the tumor is more towards BRCA2 positive, it will be either ER positive or less often triple negative and more specific, similar to the sporadic cases. So that is what the BRCA2 gene positive cases will reflect on. So here there is a lump in a patient. So both the clinician and patients will be in anxiety what it could be. Okay, so either here is a quick answer where it comes towards the FNAC. So FNAC is a simple procedure, the fine needle aspiration cytology, where we insert the needle into the lump and we take the little bit of the tissue along with the blood and we study that. So that is what is done in FNAC. What are the advantages of this FNAC? So it's basically a quick procedure where it's done in OPD and lesser complication with minimal pain, and cost is also very less compared to the biopsy or surgery, and we also get the result very quickly. That is the main advantages of FNAC. So for UG and PG, I'd like to highlight what are the things you should see as a PG in a requisition form. So should check the patient detail, clinical information you have to get about their family history and everything, and ultrasound and mammogram is also must. Pregnancy, lactation history, previous history, family history, reassurance is very important. As a PG, you should tell how the procedure is done. You should not overwhelm and do it. So you should always explain the procedure and very nicely you should give a confidence to the patient, then you do the procedure. Okay. So how the FNAC is done? Once the lump is identified, try to palpate and fix the lesion. Then the lesion is pierced with a 21 to 25 gauge needle. So then the plunger is withdrawn where without exciting the lesion and without releasing the plunger of the needle is moved in and out towards the direction, and then the needle is withdrawn and then the smear is prepared. So that is how we do FNAC, fine needle aspiration cytology. Okay, so once that is done, you usually see the cells like this. It will be in tight cohesive clusters. As you see in this image, that will be a border which is typically protected by, that is your myoepithelium cells, which will look very flat cells. Okay, once the myoepithelial cell is the border is gone, that is the loss of myoepithelial cells, so then the clusters will become something like this, loosely just spreaded clusters. Whereas you see in the previous image it's a tightly cohesive clusters, whereas in this image you can appreciate it's very loosely packed. Okay, and we have to know a little bit about the triple test. What is triple test? It includes the clinical breast examination, ultrasound mammography, FNAC, core biopsy. So all these three is very important in giving the diagnosis. Okay, and also what is the aim of triple test? They diagnose with the accuracy, pre-operative diagnosis will be done, excision biopsies can be performed. So that is what they are trying to mainly say about this. So next a little bit we have to know about what is BIRAT's code. That is a breast imaging reporting and data system. The category 0 is incomplete study where it needs additional imaging or prior studies. Category 1, that is your negative, and the routine screening is necessary. So category 2 is benign where the routine screening should be performed. Category 3 is probably benign whereas the short-term follow-up should be needed. And category 4 is suspicious where biopsy is must. And category 5 is highly suggestive of malignancy, so appropriate action should be taken. And category 6 is suggestive of malignancy, so appropriate action should be taken, that is your biopsy should be performed. Okay, so this is all about BIRAT's code. So what are the limitations of FNAC? So everything has its own limit, right? So in this, the sensitivity is mainly depends on the operator and cytopathology. So who has done the procedure is responsible, how much material we yield and everything. Okay, and it may be inadequate due to the procedure defects, and it cannot access the tissue architecture. It usually, we are studying about the cells but not about the architecture of the tissue. Okay, so they usually cannot distinguish between DCIS, that is ductal carcinoma in situ, and invasive carcinoma. So that is also one of the most important key feature. They cannot provide receptor status because we cannot do all the ER, PR and hormonal things in this particular cases slides. Okay, because if in this the cell block is done now, we can see the ER, PR and everything, and tissue architecture can also be a little bit enhanced. And this is the latest guidelines according to NHSBP. We categorize it into C1, that is inadequate, and C2, that is benign, C3, that is atypical, probably benign, and C4 is suspicious for malignancy, and C5, that is malignant. So this is the category of reporting system. So then moving on to a little bit about the grossing. So we saw about anatomy, histology and also cytology, and moving on to histopathology grossing. So grossing is very important tool as a pathologist. The postgraduate should learn about the importance of grossing. Okay, so why am I showing this container? So here the formalin is very essential. As an interns or postgraduate, you should be very careful, and you should know always the specimen should be placed in a wide mouth container, or else what will happen, the tissue, whatever, the uterus or something, it could be breast, whatever the procedure is done, you are going and inserting in very tight, which is not sufficient for the particular organ. What will happen, it will lose its architecture. You are destroying the organ, and the amount of formalin is also very much important. So how much amount of formalin should be given for each specimen? It always 10 times higher than the volume of the particular specimen. So you should always have that calculation. Don't use very less formalin for the sample. It should be 10 times of the volume of the sample. Why? Because this formalin penetrates only 1 mm per hour. So all this antigen should be preserved, especially in breast pathology where we are studying about hormonal status. It's basically depend upon the antigen which is present in the breast. Okay, so once you don't fix the specimen properly, we lose these antigens, and that will result in false IHC reports. So that is why the importance of the specimen is very important from on table towards the diagnosis. Until that, all the process is very important. So what are the types of breast specimen we receive in histopathology? It could be core needle biopsy, skin needle biopsy, lumpectomy, simple mastectomy, modified radical mastectomy. So how the grossing should be done? First we have to orient the specimen. So how do we orient the specimen? Usually if we receive any lumpectomy specimen in cases of phyllodes, it's very important in margins. Why? Because phyllodes is kind of a leaf-like tumor where it can spread to any margins, and it has a the kind of recurrence is more common in phyllodes tumor. So it's very important to give margin clearance. That is why always the orientation should be confirmed with the surgeons. Always the short is superior and the long is lateral. Okay, so you have to mark the orientation of the organ is very important in the grossing. And the next is external examination. So you have to look for nippleareolar complex. Is there any abnormalities, is there a tumor or ulceration? All these things should be noted as a pathologist in the external examination. So then moving on to serial slicing. This serial slicing is very important because now you have to do in 1 centimeter again and again because the formalin penetration is very small. So always insert a cotton in between with the formalin. Okay, 10% neutral buffer formalin should be done because the serial slicing is very important to fix the tumor and fix the antigens. Okay, so next one is describe the tumor properly. How much is the size and how big it is, and whether it has areas of necrosis or something else is there. You should mention all those things. Okay, then the margins are essential because surgeons needs it most, because whether it is very clear or not, we have to report it. And the lymph node, obviously you have to take axillary lymph nodes and also the other lymph nodes if it's separated submitted separately like sentinel lymph node. So all these things should be used cautiously, should be grossed. Okay, so this is just a diagram where we had compared it with how to gross. So first section should come from nippleareolar complex, then is your deep resected margin where you can see down. So all the resected end is your deep resected margin. So one section should be given from that, and the next one is all, if you have phyllodes or something, superior margin, inferior margin. So all this area should be given. And the next one is tumor section, and you have to give along from the far from the tumor also few sections are given. If there is 2 tumor, then 2 different scenario. Deep resected margins and everything should be given for 2 different tumors also. So the grossing is very important tool as a pathologist. So what is the meaning of inking margin? The positive ink margin means where the cancer cells come right and sit over where the ink is placed on towards them. So that is what the positive margin indicates. So in this image we can see clearly we have divided into 3. If the tumor cells are present towards the below image, you can see there is a yellow line where the tumor cells sit on towards the ink. So that is a involved area. Whereas the next one is it's close towards the 2 mm. So that is the closer margin. Whereas clear is more than 2 mm. That is a tumor is away from the margin more than 2 mm. That is a clearing of the margin is seen. Okay. So what are the take home points here? So you should know the sunflower, which is very essential. You can remember like that. Lumen will be there. Petals have 2, that is epithelial cell inner layer, and outer layer is compared with myoepithelial cells, and the stem is compared with the duct, and the fibroblasts are compared with the leaves, and the whole unit is called as TDLU, terminal duct lobular unit. You have to know about triple test, clinical breast examination, ultrasound mammography, FNAC, core biopsy, and the importance of formalin is essential because we should not lose the antigen and get the very false report of IHC. So always 10 times the volume of specimen, so remember that. And grossing is very important tool. I told you how to gross. The section should be given, all those things we have seen. So section from the tumor, lymph nodes, adjacent breast tissue, margins are very essential in the grossing elements. Okay, so thank you very much for listening, and I hope so this class is very much useful for UG and also the postgraduate students. So let us see with some other new topic in the upcoming classes. Until then, bye bye.